We start straight away with the next session on primary sclerosing cholangitis, and it's my great pleasure to have Michael Trauner from the University of Vienna as chair of this meeting, and Peter Szitányi from the University of Prague as co-chair. And so please, Michael, it's all yours.
Yeah, thank you very much. I think we had an exciting first session, and we are really all very grateful to EMA for putting this together. And without further ado, I would ask the speakers to really adhere to their time schedule. I always will try to be a role model, and that we have enough time for discussion. And with that, without further ado, Martine Walmsley will talk about the patient perspective, and I think you're already in control of the mouse, right?
I am, thank you. So hello everybody, I'm Martine Walmsley and I'm a PSC patient. I've had PSC for 12 years now. I run the UK-based patient organisation PSC Support, so thank you for asking me to talk. As the EMA PSC patient expert pool, I've worked with Larissa Delanoy and Marlene Catté to provide today's patient perspective, and they are here today just that way, waving. I'm going to give you a quick overview of the impact of PSC on patients and then talk about the patient perspective on clinical trial design issues. I'd like to start by emphasising that there are no medical treatment options for people with PSC, and because of that, people are dying. Patients have nothing to slow or halt the progression of PSC and its complications. And this large study looked at data from over 7,000 patient records over a 30-year period in 17 different countries, and they found that nearly 40% of PSC patients either needed a liver transplant or died, and just over 10% developed a primary hepatobiliary cancer, mostly cholangiocarcinoma. So it's safe to say at the present time there is no solution for PSC. And PSC patients are dying or having serious complications, but not only that, they're suffering with daily debilitating symptoms. The two patient organisations, PSC Support and PSC Patients Europe, conducted two surveys to gauge the patient perspective of having PSC, and I'm going to show you the results of one or two questions from them. We asked patients to report symptoms experienced in the previous 4 weeks for PSC Support and 6 months for PSC Patients Europe, so it was self-reporting symptoms from the near past. And our surveys found only 5 to 12% of patients reported having no symptoms. We found the most common symptoms reported were fatigue, and about 3/4 of respondents in each survey cited fatigue as a major symptom, and pain and itch, again around half in both surveys. And pain is important and significant to patients. It's often overlooked, but it's a major problem for many as it's not well controlled. And from our contact with thousands of patients on our online communities and meetings, we know that pain and fatigue occur regardless of the stage of disease. So these are difficult symptoms to live with on a daily basis. And to add to that struggle for patients, we don't know what symptoms or complications will strike or when, making PSC full of uncertainties. When I was diagnosed, my daughter was a little baby, and I didn't think that I would live to see her go to school. She's 13 now, and I'm still here, but so are all those uncertainties. So am I typical? Well, it seems so. Another question in our surveys asked patients to describe the most difficult part of living with PSC, and nearly 3/4 of respondents said that the emotional impact was one of the most difficult aspects. And nearly 2/3 of those emotional difficulties were around uncertainty about the future. And around 2/3 in the surveys said symptoms were the most difficult part to live with. And these impact on every part of daily life, on our work, on our education, our social life, and our thoughts and feelings. In the long term, patients worry most about early death, about disease progression, about needing a liver transplant, about becoming too ill for a liver transplant, PSC returning after the liver transplant, about cancer, and repeated bile duct infections. And day to day, because of the symptoms, you never know what the day will be like. You ask yourself, will I need to change my plans? Will I need to call in sick today? Will I struggle to look after my children? It makes us socially unreliable. which in turn can lead to social isolation and other psychological issues. Patients feel helpless because of having a disease that no one can treat or say what's going to happen to them. There's a huge physical and emotional burden associated with having PSC. And one patient said, the most difficult thing is trying to lead a normal life while suffering from symptoms that most people don't understand or can't relate to. And you know, that's all people want to do, is live a normal life, just like everybody else. The lived experience of PSC is a huge area of unmet need for patients. If you're thinking about improvement in PSC in a clinical trial, then please remember, to a patient, improvement isn't improvement without thinking about quality of life and symptoms. And from our patient surveys, patients have told us that they want medicines to give us peace of mind, allow them to work and lead an active life. Therefore, patient-reported outcomes and how to measure them should be incorporated into every clinical trial. And remember, our most common symptoms are fatigue, itch, and pain, and we'd like to see all clinical trials collect data on these, not just trials directly assessing symptoms. And instruments need to be developed focusing on PSC-specific quality of life. And PSC patients are already involved in PROM-related activities. At the moment, there are two PSC-specific quality of life measures under development, and the UK PSC tool has been driven and funded by patient organisations, which gives you an idea of how important PROs are to PSC patients. And equally, post-authorisation, there's real value in data from PROs, and it's important that an effective medicine is made available and accessible to patients without delay wherever they live, and we should plan for that from the outset. PSC patients don't want to die early, and they don't want liver transplants or to get cancer. We want new drugs to help us live as long as possible, as well as possible. And in an ideal world, the next medicine would be a cure, it'd be a silver bullet, but we're realists. So at least we want patients to at least live longer, even if that is with PSC. And we want medicines to reduce our risk of complication and infections, recurrent PSC, cancer, and help us understand what's going to happen to us. Surrogates. So patients don't like or trust surrogates, nor do they think they're the best way to judge a treatment. But the unmet needs of people with PSC need to be resolved as soon as possible, and the surrogates speed up trial duration, so we accept them. We agree that development programs to produce evidence towards validating endpoints is important. And we'd like this to go one step further, and there be a coordinated effort to include common exploratory endpoints in trials. We would like to see the use of new and emerging technologies with a view to replacing biopsies once and for all. And we would urge investigators to consider longer-term outcome observation when using surrogates, as long as possible, to be confident that these drugs really do demonstrate a positive change. And we'd like to see more coordinated data sharing, especially placebo data. Plus, we applaud Martine's work to address the challenges of using and reusing natural history data. We should be doing everything we can to help PSC patients to live longer, and that includes using all the data to the max. But we know it's not that simple. The reality is that there are many different phenotypes of PSC. An important group is children and young people. We know that biochemistry fluctuates naturally and following cholangitis episodes. So how will investigators address this? A cholangitis flare is a major episode for PSC patients, and as such, this group is highly motivated to take part in clinical trials. So we'd like to see wider screening windows and opportunities for rescreening once the flare has subsided. And in particular, we'd like to see appropriate IBD measures studied in trials, especially in children, as well as the impact of the intervention on coexisting diseases. UDCA, or URSO, we agree that a stable dose of URSO should be allowed in clinical trials. Stopping UDCA is very, very difficult mentally, and many patients don't want to come off it unless there is an effective alternative. We would like to see more trials like the recently reported MGM 282 trial with broader eligibility criteria. It included more phenotypes than other studies. We want the treatments to be approved for the majority, not the minority. So in summary, we know that there are challenges ahead, and we would like to see researchers, academics, patients and industry working together and collaborating to develop and validate endpoints for PSC and move forward clinical trial design. As patient advocates, we're ready and we want to work with all the stakeholders in a positive, collaborative way. We're well organised, trained and have expertise within our networks to support and add value to research. People with PSC are suffering with the risk of early death and poor quality of life. There are no medical treatment options, so time is of the essence. Our urgent goal should be to validate appropriate non-invasive endpoints and let the focus not solely be on surrogates. It's critical to always consider quality of life in clinical trials and include PROs as in endpoints. So let's be coordinated and pool our knowledge and act together to accelerate getting medicines to PSC patients, because ultimately we want to live as well as possible, as long as possible. Thank you very much for your attention.
Thank you very much, Martine, for your very clear presentation. Also, the point of POs has come clearly across, I think. As always, we allow some burning questions. Gideon.
So Martine, as ever, excellent. But can I challenge you, seeing as we're friends? If I were to tell you that I thought that the ongoing use of URSO was slowing down the time it takes to get drugs that really make patients with PSC live longer, do you think you might change your opinion about the use of URSO when we talk about new drug discovery? Because I'd be honest and tell you, I think your position may actually mean that it will take longer to get a drug for PSC.
I appreciate your comments, and I've spoken on behalf of the PSC community. Personally, I'm one of the patients that came off URSO to try and go on a trial. I think there's work to do, and it's about communication. If there is a trial out there and that shows a convincing potential to make things better for PSC patients, I think that the patient organisations have got a role to do in giving information to patients potentially going on trials so that they can make their own decisions. And, you know, maybe with the right information and your charm, they'll come off URSO.
No, I was going to relieve I was going to leave that charm to Cyriel, but I do think it's an important point, because actually we're learning from published and unpublished data that the use of URSO is making it very hard to understand some of the trials that we're doing, and it may actually be it means that drugs may not look as good as they potentially are. Yeah. And that may not actually benefit patients with PSC, and that's a realistic issue, and it is a job for all stakeholders to try and explain to our patients that when we do a clinical trial, it's for a very good reason. And if we thought stopping the UDCA, there was a lot of thought would have gone into that.
Yeah. I'd like to save that very important issue for the general discussion. We will revisit that. I think that was a very important point. Yeah, thank you very much. In the interest of time, I would suggest we continue, and you have passed on the mouse already to Douglas Thorburn. He will talk about definition, natural history, and lack of approved therapies. So, Doug,
thanks very much.
Set is coming up.
And thanks for the invitation to come along to this important and interesting day.
And I think, meanwhile, there are also several of our colleagues from the US have joined us via the web, right? So, welcome at this time of the day.
Thank you very much, and I'll try and stick closely to time. So just to kind of run over exactly what Martine said in her excellent patient perspective, I think there's an enormous challenge from PSC for patients, but also for the clinicians that look after them, after patients that have PSC. And we're talking about the lack of effective medical therapy which is obviously extremely important, but that shouldn't be seen. That should be seen within the context of all the other challenges that exist in relation to this disease. And Martine very nicely outlined the issues of patient experience. I think it's also in comparison to the PBC discussion that we had earlier on, it's even more complex in the sense that there's this strong association with inflammatory bowel disease, and there's probably a wider group of phenotypes of disease that exist. So there's lots of challenges. In terms of the definitions of PSC that we work with, in the 60s, PSC was a disease that required a laparotomy, so we've moved forward somewhat. But the diagnosis now is based on a constellation of clinical parameters, so elevation of cholestatic liver enzymes, the evidence of biliary tract disease on cholangiography, and then the exclusion of secondary causes of these changes, particularly gallstone disease, previous surgery, but other things like sarcoid and HIV, for example. And while there are changes on cholangiography that are consistent with the diagnosis, there's not really features that are entirely diagnostic of PSC and no other condition. And this is the definition that was established in the EASL guidelines in 2009 and is the one that we largely work to currently. And this defines PSC that's clinically apparent. And as Martine described and I showed in the earlier slide, that there's quite a variation and unpredictability in the course of the disease in patients that have been diagnosed. But what we haven't been able to recognise at what time the disease starts, what does the beginnings of PSC look like because of the absence of a diagnostic test, unlike AMA, say, in primary biliary cholangitis. But there's some data emerging in this, let's say, subclinical or preclinical PSC. And this is data from Oxford. Roger Chapman produced an abstract in 2007 reporting on 50-odd patients who underwent MRIs when they had normal liver function tests and pancolitis. And they described a portion of those patients that had MRCP evidence of what looked like PSC. And what they did in this follow-up study was to blind two radiologists to the interpretation of the MR scans for patients that were positive controls with what we would call PSC and patients who were healthy volunteers with no reason that particularly they would be expected to have PSC. And they found that there was 15% or 14% of patients that had abnormal cholangiograms. And when they looked in patients that had colorectal cancer or colorectal high-grade dysplasia, they found it to be 21% of patients who had normal liver function tests and ulcerative colitis that had features of PSC. The majority of these cases were in intrahepatic ducts only, as opposed to what we know of classical clinical PSC, where it's the majority of patients have intra and extrahepatic disease. And then they reported in the most recent abstract, this has now been submitted, I think, to Gut, that with the 7 patients they'd identified and 4 additional ones that were followed for a median of 8, almost 9 years, that some of these patients with normal liver function tests went on to develop abnormal liver function tests. There was evidence of radiological progression in a portion of these patients. Some developed colorectal pathology or dysplastic pathology. And one of these patients went on to develop a cholangiocarcinoma after around 7 years. So it raises the possibility that there's something to this disease, this preclinical disease, but the problem is we don't really know the natural history of this group of patients. And this is further data that came from the Norwegian group in the Ibsen cohort. They looked at a large number of patients who were followed up with colitis, with inflammatory bowel disease for 20 years, undertook MRI scans on them, and found that although in the cohort there were 2.8% of the cohort had a diagnosis of PSC, there were almost 3 times as many patients in the when they undertook MRIs that looked to have evidence of PSC. Again, it was predominantly intrahepatic. It was similar, if not higher, prevalence in Crohn's disease than it was in ulcerative colitis. And the other very interesting finding in this study was that actually these subclinical cases were substantially more commonly found in females, suggesting that there may be the disease may be more common in females than we expect, but that it's in the subclinical stage of the disease. So it highlights that the disease is probably not just the clinically apparent patients that we see. There's this preclinical PSC, but at the moment we know too little about the natural history, and it would seem a very difficult group of patients to justify studying with interventions. And it's just to say that there's been an ongoing endeavour for the last year or so. Gideon and Cyriel are involved in this in terms of developing new definitions for PSC, particularly with a view to aiding clinical trial design. And I've just jotted down some of the topics that we've been debating and discussing. Every question seems to open a new discussion, and it seems that the job expands with every time we get together. But I think we will probably manage to nail things down and produce something in the early phase of next year. What about natural history? Well, most of the early studies of natural history in PSC were single-centre reports. This was 8 centres in Sweden reporting natural history of patients that were diagnosed in the 90s and was published in 1996. As I mentioned, majority of patients have both intra and extrahepatic disease. The follow-up was for over 5 years. And they plotted survival curves for those patients who didn't have symptoms, and that was about 40% of patients, versus those patients who had symptomatic disease. And they showed a significant difference in outcome between those two groups. But overall, the median population survival was 12 years. And this married up to the 2 earlier publications from the Mayo Clinic and King's, which reported almost identical median survival periods of 12 years. I just wanted to highlight a couple of things about these early studies. The first thing is that the commonest endpoint that occurred in these populations was death. So death was substantially more common than liver transplant as an endpoint. And those patients that died, the majority of them was due to the consequences of cirrhosis or complications associated with cirrhosis, with cholangiocarcinoma the second commonest cause of death. When patients were underwent liver transplant, this was a very early series from King's, the majority were for undertaken or registration of patients was for complications of cirrhosis or variceal bleeding. The more recent data about natural history has very helpfully come from Cyriel and from Holland, where he undertook a population-based study covering approximately 50% of the Dutch population, getting data from 44 hospitals with follow-up of just under 9 years. In this population, there were interesting findings in that the patients, overall, the median survival was over 21 years. So that was survival to liver transplant or PSC-related death. But when they looked only at those patients who were cared for in the liver transplant centres, there was evidence of referral bias, which probably is very relevant to the earlier data from Mayo and King's, where the reported survival in the patients that were looked after in the transplant centres was substantially lower. But it gives probably a much more balanced outlook of the prognosis of PSC overall, and gets around this issue of referral bias that's been referred to already. Martine's already mentioned the other recent paper about the large iPSC cohort, 7,000 patients. In that study, the median survival was 14.5 years. And again, I just wanted to highlight that there's been an evolution such that in this sort of more recent era, the outcome that's more common is liver transplant as opposed to death. And in those patients that die, the commonest cause of death is cholangiocarcinoma. So I think what we're seeing is not a change in the natural history of the disease, but we're seeing a change in the way that we apply liver transplant to this population. And I think that's demonstrated by this data that comes from Norway, was published in 2017, Tom Carlson and the Oslo program's experience of transplant for PSC, where unlike the early series of patients that were transplanted for PSC, the indications for liver transplant are substantially more varied, and being transplanted is not the same, or undergoing registration for liver transplant is not the same endpoint as it was in the studies in the early 90s. And there's many countries, the UK included, which continue to register patients mostly for liver transplantation for cirrhosis or its complications. So it's just to kind of highlight the evolution in practice in transplantation has had has produced a change in what we see as the natural history. What about therapy? We've heard discussions about the importance of symptom-based treatment. There's little evidence to support what we do. The discussion's much the same as the treatment of these symptoms in PBC. In terms of changing the natural history of the disease and extending life for patients with PSC, as we've heard, there isn't a licensed treatment we have. The only treatments that we apply to patients with PSC with the anticipated impact on the natural history of the disease are surgical treatments, either liver transplantation, resection, cholecystectomy, and you could probably include ERCP in that. I'm not going into any detail about the role of ERCP, but the evidence that ERCP changes the natural history of disease are based on predicted outcomes of patients who've undergone ERCP against using the Mayo risk score versus the observed outcomes in those patients after they've had ERCP. So there's no prospective data that show that ERCP alters the natural history of the disease. In terms of transplant, it's an excellent intervention. And in terms of the outcomes, this is just 5-year outcome for liver transplant. PSC is associated with some of the best outcomes. And in terms of life expectancy after liver transplantation, this is UK data from the mid-2000s. James Newberger led on the publication. The life expectancy of patients with PSC who undergo liver transplant is high, so there's a lot of utility out of transplanting patients with PSC. But it's not the end of the condition. It recurs in about 20% of patients. This is data from the UK follow-up. This was follow-up for 9 years. 14% of patients developed recurrence. This was associated with the presence of colon or presence of UC post-liver transplant and younger age. And what was demonstrated in this study was that there was a significant increased risk of graft failure in patients who had developed recurrent PSC, and also a composite of graft failure and death. So there was an increased mortality in those patients that developed recurrent PSC. So it is an important disease, although it clearly is PSC is a rare disease, and this is a much smaller subset of those patients with PSC. In terms of treatment, we know there have been a number of clinical trials of UDC and PSC. I wasn't intending to go into them in detail. Consistently, what's been demonstrated is an improvement in liver biochemistry, but that hasn't played out in terms of improvements in other clinical endpoints. In fact, the only positive study for treatment in PSC is the benefit of placebo in patients receiving high-dose urso. So unfortunately, UDCA has not delivered, at least on clinical endpoints. And you could criticise, or one of the issues of this of these studies is the power of the studies. So this Olsen study, to reach the primary endpoint, they were needing to recruit 350 patients over 5 years, and they managed only to recruit 220. So it was underpowered to reach the primary endpoint. And we undertook a Cochrane review that didn't tell us anything new particularly, but that confirmed that there was no clear evidence against clinical events with UDCA treatment. So just to summarise, we use the EASL 2009 definition, but this underestimates the true prevalence of PSC. And one of the challenges is that the patients that don't fulfill that definition currently, we're not so certain about the natural history of the disease in those patients. We're working on new definitions. We hope to have them later this year. The clinical endpoints in PSC arise over decades. From the Weissmuller IPSC paper, the event rate reported was 5.1 events, liver transplant or death, per 100 patient years over the period of follow-up. And the incidence of cancer, HPV cancer, was 1.4 per 100 patient years follow-up. So it's very challenging, and expensive to design clinical trials based on those endpoints. And then finally, just to say that liver transplant remains a real success for patients with PSC, but you could flip it the other way and say if we have to take a patient to liver transplant, that demonstrates our failure to deliver care by other means to delay or prevent the progression of disease to that point. So thanks very much.
Thank you very much, Douglas. That was excellent. Any burning questions? I don't see a question. Please, one short question, short answer.
Yeah, hi. My name is Tassos Grammatikopoulos from King's College Hospital. As a pediatrician, I'd like to set the base clear about what pediatricians consider as PSC and what our adult colleagues perhaps consider, because it was interesting to see, Douglas, that in the IPSC study group, there's no pediatricians involved in that, in the members' state. So just to say that for us, it's a seronegative condition. It's histologically based diagnosis, and the outcome is different than perhaps our PSC patients are considered.
Thank you very much. Henkjan Verkade will address that in the last talk.
Can I just mention
yes.
one thing? It's just say Martine is part of the group working on definitions. So there's 6 of us, 6 or 7 of us, and we've definitely got paediatric input into that discussion. And the aim is to cover the disease in childhood and in adults. So,
okay.
Thank you.
Sure, we'll address that at the end after Henkjan's talk. Thank you very much. And Cyriel will have the difficult task to address the currently proposed endpoints. I think we've seen the need and the difficulties, especially when it comes to the low event rate. So what are the endpoints? And Cyriel has been very instrumental in previous meetings, and I think also in advice to EMA how to develop this. And we're looking forward to your concise presentation, which will be absolutely on time as always. Cyriel.
Setting the stage for 15 minutes. Thank you very much, and I thank the organisers for inviting me to give this presentation on currently proposed endpoints in PSC, the search for reliable surrogate outcome parameters. While it is impossible to address the whole array of candidate endpoints, the pro and cons in different situations, phase 2, phase 3 trials, I decided to limit myself to some general discussion on requirement for endpoints, and then see how these apply to the endpoints that come out most prominently in the reflection paper. And Martine, I have to apologize, but I unfortunately, in the interest of time, I cannot discuss pros and endpoints that address symptoms, notwithstanding the great importance of those endpoints. But maybe we can come back to that in the discussion phase. So I will only talk about disease modifiers, endpoints that are supposed to measure stopping or halting disease progression. My main sources for my talk are the position paper from the International PSC Study Group, which we produced in 2015, and the design endpoints for clinical trials, the guidance paper from FDA I wrote together with Keith Linder and two officials from FDA, Lara Dimmick and Ruby Mehta, and of course the recent reflection paper produced by Elmar Schabel and colleagues. When talking about biomarkers that are supposed to reflect how a patient feels, functions, or survives, it is important to mention this hierarchy of endpoints that was put forward by Thomas Fleming already in 2005. Level 4 means you have some measure of biological activity. Well, there's plenty of them in PSC. Level 3 is what we're talking about, non-validated but reasonably likely to predict benefit surrogate type endpoints. Level 2 is a validated surrogate endpoint such as HbA1c in diabetes trials, and level 1 is a true clinical efficacy measure such as death or time to liver transplantation in cholestatic diseases. Now, in order to get a non-validated reasonably likely to predict benefit surrogate endpoint from level 3 to level 2, one needs to combine level 3 and level 1 endpoints within the setting of a rigorously conducted clinical trial. Now, there's 5 of them in the recent literature from the last 25 years or so, which had a longer follow-up, 2 to 5 years, and number of patients that was a bit bigger than the pilot trials that have been done earlier. And if you look at the last column, the results, on the clinical endpoints, so occurrence of things like death or liver transplant or cholangiocarcinoma, there was either no change of the drug or there was a worsening, and at least there was no conjunction with what the surrogates did, like alkaline phosphatase or bilirubin or histology. So this could mean several things. 1, it could be that the drugs were not working. Or 2, it could be that the trials were vastly underpowered, and that is the case. If you look at the largest trial with the longest, with the highest patient years of follow-up, the Olsen trial of the high-dose URSO from Scandinavia, they were able to recruit 290 patients in a follow-up of 5 years' time. So they ended up with 1,160 patient years of follow-up, while they had estimated they would need about 1,760 patients for a power of 80%. So all these trials were vastly underpowered, and for a trial, a 2-to-1 ratio, active drug versus placebo, 2-year trial with 5 years of follow-up, and a very high effect rate of even 0.5 hazard ratio in the active arm, you would need at least 2,000 patient years of follow-up, so 400 patients in a 5-year follow-up trial, which is simply not feasible in a rare disease as PSC. So we have to relate and resort to surrogate endpoints. And what are the requirements you could think of that are needed for such surrogate endpoints? 1, of course, it should be measurable and interpretable. It should be sensitive to change. It should have a natural variability, which is either stable in the placebo group or contained, showing a trend in one direction only. And preferably, it should be on the pathway to a clinically meaningful endpoint. In the position paper, consensus process, out of an array of 18 elicited potentially interesting endpoints, we in the end came up with a short list of 5 with a ranking. Alkaline phosphatase was the most preferred one, and I will discuss alkaline phosphatase and histology because these two came out as most prominent in the reflection paper, and see whether those requirements you could apply are satisfied in these 2 endpoints. Alkaline phosphatase. It is, of course, the biochemical hallmark of cholestasis. It has been used in all studies, 26 actually, in the past 25 years. But as mentioned earlier, there has been no significant association with clinical outcomes observed so far. But there have been a number of observational trials and also post-hoc observational studies from these clinical trials, and the most compelling one is the Lina Lindström paper published in 2013 in CGH, showing the results from a 10-year post-hoc analysis of the 5-year high-dose urso study from Scandinavia. And they could observe that in patients within the trial that were able to reduce their alkaline phosphatase within the first year of treatment or placebo to normal levels or 40% reductions, irrespective of treatment allocation, so urso or placebo didn't matter. There was a clear distinction between patients who did better and worse. So, and this is a sort of a decision rule which could lead to a proper stratification or selecting patients for trials that is quite reminiscent to the PBC data. And this is data from our own population-based cohort where we looked at the predictive power of alkaline phos at diagnosis and at 1 year. These are the data from 1 year, and we could see that with a UNO-C statistic that the predictive power lasted until about 17 years after measurement, and the optimal cutoff, making a distinction between worse and better prognosis, was 1.3 in our cohort, which is reminiscent of the other studies that found 1.3, 1.5, the upper limit of normal, as being the threshold of the making the biggest distinction between good and bad, worse prognosis. Another requirement would be that your alkaline phos level is either stable or showing a consistent trend in your placebo group. So what's the natural history of alkaline phos? For this, we did a small exercise using 71 patients from Amsterdam and Birmingham from our outpatient clinics that could be potentially eligible for a phase 2 trial, so they were in a stable situation. And we found that in 164 one-year intervals, the delta on group level was only 5.7%. So the variability on group level during the natural course is limited. However, it should be noted that the standard deviation, so within patient, is 36%, which is relevant if you want to apply a decision rule, calling a patient a responder yes or no. A normal decision rule would be that at least you should lower more than one or at least one standard deviation of the variability. So this is relevant for designing clinical study focusing on the decision rule per patient. And the same was found in the recent simtuzumab trial, where in the placebo group the variability on group level was very low, but the standard deviation or the range was pretty high. So alkaline phosphatase seems to be a good predictor and also therefore a good stratification tool or inclusion tool for selecting patients in your trial. But as Fleming and de Metz already mentioned in 1996, a correlate does not a surrogate make. So other criteria would be: is it interpretable, and is it sensitive to change, and does it change in the same direction as your patient is going with regard to, for instance, complaints? Now, there's limited data on that. We did a retrospective survey in patients who underwent ERCP with short-term stenting because of symptomatic dominant strictures, and saw that after 2 months in patients who were treated successfully, pruritus, fatigue, cholangitis, and right upper quadrant pain all went down significantly, and it was nicely concurrent with lowering of conjugated bilirubin, alkaline phosphatase, and gamma GT. And currently, we are doing a post-hoc analysis of the Dilstan trial, where we had on several occasions cholestatic complaints plus biochemistry, and are looking into the correlation between these two measurements. And the first data look very promising, but we still have to do some more analysis before we want to bring this out. So, in summary, echoing the IPC study group statement from 2015, we felt that alkaline phosphatase is widely recognized as a clinical measure of cholestasis. Currently, albeit not formally validated, it is regarded as a potential surrogate outcome parameter. One of the other endpoints that comes out of the reflection paper is histology, which has, of course, a number of advantages. It directly assesses disease activity in the target organ and as such has phase and construct validity. It has been the gold standard to assess liver fibrosis and cirrhosis and is acceptable to regulatory bodies as a level 2 endpoint when it comes to, for instance, progression to cirrhosis and prevention of cirrhosis in your active arm group. And also it provides human histologic material for mode of action investigation and safety assessment. It also comes with a few disadvantages. There can be sampling error, which is mainly known for diagnosis. The pathognomonic sign of onion skinning is found in only a minority of patients when you do a liver biopsy, PSC patients. And of course it's an invasive procedure, not completely devoid of complications. Is it interpretable? When you do a liver biopsy and you stage it, does that tell you something about how far the patient is in his disease stage? Well, this is very old data from Russell Wiesner from the Mayo from 30 years ago, where he found that according to the Ludwig stage, you could nicely see that patients fared worse when they had an increased Ludwig stage. This is consistent with data from Oxford, which I borrowed from Roger Chapman, same data. And this is a table from the recent validation study we did using 119 biopsies from 7 European centers, which we put to 6 expert liver pathologists, which we locked up in the pathology department for 2 days, and looking at the performance of 3 different stages, the Ludwig stage, the Ishak stage, and the Nakanuma stage, which was initially developed for PBC. And we found that with regard to the correlation with transplant-free survival and liver transplant, the Nakanuma stage performed best. Is it then measurable? In other words, is there a large inter-observer variability? Well, in this study, the inter-observer variability kappas were between 0.56 and 0.64, which is in histology world not bad at all. And also, when we asked the liver pathologists which staging system they felt was best reflecting what's happening in the liver in this disease, they all favored the Nakanuma. In order to circumvent inter-observer variability, one could also turn to more quantifiable forms of fibrosis measurement, such as collagen proportionate area. This is a slide from Paul Dillon. We are currently, together with Doug, looking at this in PSC and find a nice correlation with liver histology as measured by experts. And there's other measurements more quantifiable, independent of observers out there also, like the one that was used in the simtuzumab trial. What about the natural variability? Is it going into all directions, yes or no? This is all data from the Mayo, where they found 107 patients who had sequential biopsies within 24 months from each other, and found that the second biopsy in patients who had stage 1 to stage 3 Ludwig, 53% had progressed, and only 40% of the patients had a lower stage in the second biopsy, which is more or less mirrored by the data from the simtuzumab trial, where in the placebo group, 52% after 2 years had the same Ishak stage, and 16% had improved, and twice as many, 32%, had progressed in that stage. So it doesn't seem that it goes in every direction over time. There seems to be either stability or some worsening. But then, of course, there is the issue of sampling variability. There has been only one study in the literature that looked specifically at this issue from Rolf Olsen, published in 1995 already, using the Ludwig stage and taking 2 biopsies, not so much from each other in terms of time, and from the left and the right liver lobe. He observed that in almost 3/4 the same stage was observed, and in the other 25% there was a discrepancy in stage. There's also data from Hamburg, unpublished. Christoph Schramm told me that they did a study where via mini laparoscopy they did liver biopsies from the left and the right lobe, scored them with a Desmet histology staging and found a discrepancy in staging in only 10% of cases. We know, of course, that there can be a large geographical difference in disease stage in PSC patients in the left liver lobe as opposed to the right liver lobe or the other way around. And it is anticipated when doing liver biopsies, ultrasound guided from the same lobulus, a large part of the variation could be accommodated for. What about safety? Here is a summary of the safety of liver biopsy in all PSC trials from the past 25 years, including the recent simtuzumab trial, where it says 670 biopsies in 230 patients in 2 years' time. In almost 2,000 biopsies, there has been no mortality reported. In general, mortality from liver biopsy is about 0.5 in 1,000 patients, so 1 in 5,000 patients. And the SIA rate, if taken under ultrasound guidance, is 0.5, which is pretty low. And to summarize this, liver histology has the potential to be a robust surrogate endpoint for clinical trials in PSC. However, of course, we want to get rid of liver biopsies, as Martine also made a plea for. So it's very important that when you perform a trial, take into this trial enough surrogate endpoints that you can correlate with this endpoint. One remark on the reflection paper: I read somewhere that a liver biopsy should be an entry criteria for a clinical trial. Maybe I was wrong, but at least for entry in the clinical trial, for making a diagnosis of PSC, you don't need a liver biopsy. We have been doing a lot of discussion, and which is still not finished in this definition paper panel process, but there's one thing we agree upon, which is that for large PSC you don't need a liver biopsy. One word about combining endpoints. The IPSC statement is that in the absence of a convincing single surrogate endpoint, combining multiple endpoints is considered advisable and should be explored further. Of course, this depends on where you are in your development program. In my mind, when you're doing a phase 1 or 2A proof of concept trial, you should maximize the chance of finding a potential contrast. So you should look, if you want to combine endpoints, you should look at a composite, in which either endpoint, if it is satisfied, means that you have a positive outcome. But when you intend to perform a phase 2B or phase 3 trial, registration trial, you should maximize the reassurance of a beneficial effect, which means that I think you should go for a co-primary where both endpoints should be satisfied in order to have more reassurance that you indeed have a positive effect of your drug of interest. And with that, I thank you for your attention.
Thank you very much, Cyriel, for being very clear on a very difficult topic. Are there burning questions or issues which we cannot address at the end? If that is not the case, I think we continue, right?
I can take over from Michael, and the reason is not I should show any efficacy as a co-chair, but the reason is that Michael is going to speak about the trials and trial designs and the potential populations for such of trials. Michael, it's your turn.
Yeah, thank you very much. So Cyriel already undertook the most difficult task, is actually defining the endpoints, and of course the study design will heavily depend on the endpoints chosen. So these are my disclosures. How does that work? Just pressing? Okay, oh, okay, yeah.
With this, here with the scroll.
Okay. Good. So now I got it. So after having chosen the right endpoint, of course, I mean, we are aware that the number of patients for study is limited. We've heard from Douglas about the issue of disease heterogeneity, and also the long and the variable, the undulating disease course. This also limits our study designs. For example, we cannot perform lead-in phase like we do in IBD and in rheumatology, followed by re-randomization, for example, based on loss of response. And the slow progression rate with the very low annual event rates, which heard about, results in long study duration. We have the variable confounding therapies. It's not only URSO, but also IBD therapies, or think of antibiotics for intercurrent cholangitis impacting on microbiota. And URSO, let's presume it's not effective, but it certainly will impact on alkaline phosphatase and thereby on study recruitment. And the exclusion of active IBD to avoid IBD therapy bias, which of course is a potential concern, may obscure a potential beneficial effect of the study drug on the gut, and the gut may actually drive the disease. So I think this is a problem of current study designs, and there are of course multiple competing endpoints, not only the classic liver endpoints, but also the bile duct endpoints such as dominant stenosis, the cholangitis, and also the colon endpoints, not only IBD, just think of colorectal cancer. So when we basically, when I talk about trial design, Cyriel has alluded to the differences of phase 2 and phase 3. Of course, I will mainly focus on phase 3, but just saying that in phase 2 we want to see target engagement. The issue of URSO weaning, I think for a phase 2 there is the point of getting a more clear signal of the study drug, and probably it's also easier to convince patients, having the problem, of course, of the rebound of alkaline phosphatase after URSO discontinuation. So you have to be in a stable phase, and the endpoints in phase 2 may very much depend on the drug mechanism, whether it's cholestasis, inflammation, or fibrosis. And we also usually allow, especially in the more recent trials, overlap with autoimmune hepatitis or small duct PSC, which we would exclude in a phase 3. The only problem here is those are two factors which are associated with a better prognostic outcome. So we may run into the same problem we know from rheumatology or IBD, that we select for less severe disease in phase 2 and then go for the more severe disease in phase 3. In phase 3, of course, the intermediate endpoints, we've heard about the combined use of histology and alk-phos actually as a co-primary evaluation currently carving out. If we, the question, of course, is can we demonstrate meaningful clinical outcomes, which takes quite a lot of time. So 2 years are probably enough for a co-primary endpoint in histology and alkaline phosphatase, but it may take more, up to 5 years, at least 4 years, to demonstrate the long-term clinical outcome. And I think the reflection paper phrased it very wisely that if the composite endpoint is not met, we may have to consider the totality of data, and we can discuss this later at the end. And there, of course, the question is, do we allow an open label or a placebo extension? Especially, do we necessarily continue for the whole study phase on the placebo-controlled phase? And I just want to remind you what happened in the pivotal URSO trial. I think we were very lucky that actually after discontinuation of the placebo phase for 2 years and then opening up to treatment for all patients, still there was a clinical difference in the long-term follow-up. So this, I think, depends very much how strong we believe in the efficacy of our study drug, whether we would allow such a study design. So what about suitable study populations? Basically, since it's a rare disease, we have to take practically all comers. So typically that would be large duct PSC. In phase 3, we would exclude small duct PSC and overlap because we think they are milder and have a more benign course of the disease. Of course, we would exclude advanced decompensated liver disease. And also when you think of bile duct endpoints, we would exclude patients with repeated endoscopic therapy of dominant strictures. And this depends a little bit on how many of the so-called bile duct endpoints we want to allow in phase 3, and we can discuss that. When we think about the alkaline phosphatase entry criterion, it's clear that URSO, as I've mentioned, will have an impact on study recruitment. And even if we stratify for URSO use, I think this is important. The question is, do we also stratify for other subphenotypes? I think with the rarity of the disease, there's a limitation for substratification. Some studies, such as the simtuzumab, also stratified for IgG4 levels. And we have to be aware that ERSO-naive patients probably have a shorter disease duration and probably less advanced disease. So we're not going to see the impact of ERSO or not. I think we're also going to see the impact of disease duration, which is something to keep in mind. And of course, it's a question, do we enrich for risk of fibrosis progression and reaching clinical endpoints to actually hit clinical endpoints? When we look at the current phase 3 design, I think we have two extremes which are currently excluded from ongoing trials. On the other hand, the two benign early disease, and this not only accounts for small duct PSC and overlap, but also, as we've heard from Douglas, the early PSC changes on MRI. And perhaps this is the ideal study population for the future, because this is early disease. When you see what we are doing in rheumatology, or for example in IBD, we treat early on. In rheumatology, sometimes rheumatoid arthritis diagnosed 4 weeks ago in some recent trials. And I think the Norway experience, this of course will mean that we will rely on imaging markers. We cannot even rely on alkaline phosphatase, since this will be normal in a significant proportion of patients. On the other hand, we have the too severe or late disease, the dominant strictures requiring endoscopic treatment. I think one of the reasons is, first of all, the criterion is subjective, and also endoscopic treatment is extremely subjective. So when we allow that, I think we also have to define what kind of endoscopic procedure we are going to allow. Recurrent cholangitis, patients who have recurrent cholangitis, we've heard they are at urgent need, but those are typically excluded from studies, although you could expect an impact on such an enriched study population. And I've mentioned decompensated cirrhosis and also active IBD, since that may drive the disease and the study drug could have an impact. And I think we have a little bit the dilemma of selecting patients with advanced fibrosis and trying to keep out patients who have dominant stenosis, because this goes hand in hand. And this is clearly shown that the likelihood of developing a dominant stricture in stage 4 disease is much higher than in stage 1 disease. And I think this is something which needs to be accounted for in study design. And at the end, I think it depends on where do we think that our drug works? Do we think that the drug is working on the stricture of the bile duct, which is also undergoing endoscopic treatment, or do we think we rather hit the parenchymal disease, or do we even hit the gut? So I think this is something which, of course, is much more diverse than perhaps in other diseases. So when we think about further patient selection, we may undergo the mistake that we orient ourselves too much on NASH, because in NASH we restrict patients to high-risk patients because not only they are at urgent need, but we cannot treat all of them. I think in PSC it's different. We enrich in order to reach an endpoint for studies, but actually, as it has been nicely said by Martine, all patients are probably at need for treatment, and this is something which needs to be considered. Of course, when we select for fibrosis stage, in order to look at either progression or reversal, we can do that with non-invasive tests or elastography or histology. And just keep in mind that actually where the action is not the F0 and F1 fibrosis. This data actually predicted from elastography from Christophe Perchot. So if you have F0 and F1, the disease is going to be very stable. So you may consider to exclude those patients when you want to hit clinical endpoints or progression of fibrosis, because this is where the action is started with F2 fibrosis. The same with compensated cirrhosis. We could look at histological reversal of cirrhosis, as has been stated in the reflection paper, or clinical decompensation. I think we not only should include the classic liver-related endpoints, but also bile duct-related endpoints, episodes of cholangitis, needs for intervention, and maybe this is in the general assessment of all data which come out in such a study. Of course, both the definition of cholangitis and also the need for endoscopic interventions are extremely subjective and currently purely defined in ongoing studies. And also malignancy, not only in the hepatobiliary tract, but also in the colorectum especially, and also high-grade dysplasia is an endpoint. We also could enrich our risk populations by alkaline phosphatase. And this is actually a presentation from Cyriel, which showed that depending on the levels of alkaline phosphatase, of course, also your clinical endpoints will depend on how high your alkaline phosphatase levels are, because this, in a way, also correlates how far the disease may be progressed. We can do that with ELF. Just keep in mind the 9.8 cutoff, which has emerged in many studies, distinguishing also patients who reach clinical endpoints. You are aware the same can be done with liver stiffness around 9 to 10 kilopascal as cutoff. And just keep those numbers in mind and look where we are with the current phase 2 studies. I think we've done quite a good job with enriching patients. I don't think that we were treating early stage disease. If you look at the levels of alkaline phosphatase, this is the NORURSA study, the obeticholic acid study. Only the simtuzumab study, patients had quite low alkaline phosphate, but those are medians, not mean. But also here, the Ishak score, 50% of patients had quite advanced fibrosis. And this was also seen in the Gilead FXR ligand and also in Gideon's study with the NGM compound. If you look at the ELF score, patients had the ELF score around 10. So I would say those are patients who have advanced fibrosis who were enriched in this study population. And the simtuzumab trial, in a way, we take that now as a natural history of PSC. It's a little bit what we already saw in the Lindor high-dose URSA study, that the number of clinical events was actually quite low. Cyriel has mentioned the risk of progression of fibrosis and how that was distributed. If you go to clinical events, you have to keep in mind that this was mainly driven by bile duct endpoints, such as cholangitis. And again, here we have the problem of definition, and this is a wide subjective arena. And ascites or portal hypertension or cancer, those were low events. The risk factors driving that, and that comes to how to enrich the study population, were advanced fibrosis, high alkaline phosphatase, and high ELF. And of course, we can do imaging also to stratify our patients or prognostic models, but I'm not going into details. I just want to mention at the end the NORURSA study, because this is basically the only phase 3 study which is currently ongoing. This is a Falk-sponsored trial, and actually the advice was given by EMA. That's the study design is 4 years, and patients will be included based on alkaline phosphatase. And there will be a co-primary endpoint of the proportion of patients with partial normalization of ALK-Phos. Here, the endpoint is this 1.5-fold upper limit of normal cutoff, and no worsening of the Nakanuma stage within 2 years. And there are also a number of secondary endpoints. And when you look at the study design, basically at 2 years, this co-primary endpoint of alkaline phosphatase and no worsening of fibrosis by liver histology will be assessed. And then the hope is that with continuing with the 4-year arm, plus still placebo-controlled, the prevention of PSC-associated adverse clinical outcomes will be demonstrated, including also bile duct events, such as, for example, cholangitis. And I'm not going into too many details, just mention this is a co-primary endpoint, so both have to be hit. And of course, there are also a number of other secondary fibrosis imaging and also patient quality of life endpoints included. I just want to say the definition is Nakanuma stage. So this is the combination of fibrosis, bile duct loss, and also in positive granules, which in a way also reflect cholestasis. So the Nakanuma score in a way is a little bit redundant also with the degree of cholestasis. And if you look at how the distribution is, and this is from the DeFries study, actually the majority of patients are in stage 2. So I would say based on that, there's still the chance, or there's a very good chance that that it will be possible to see movement in some direction here in this study population. What about the peculiarities? We are a little bit too obsessed with fibrosis when it comes to PSC and PBC. And here we have to keep in mind that reversibility of fibrosis is not everything. Actually, it's also stopping progression of duct loss and perhaps the holy grail, even reversibility of duct loss. So if you want to impact on the Nakanuma stage in a positive way, it's not just fibrosis the wheel to turn around, but also the number of bile ducts. And I think this is something which distinguishes PBC and PSC totally from NASH and viral hepatitis, that you also have bile duct loss and not just fibrosis, which is enough to get rid of. So it's a little bit more complex. And in the future, I think, of course, combination therapy is probably also a future to go in PSC with this complex disease. We've heard about PRO. I think they're absolutely critical. If you look what, for example, is going on in systemic sclerosis, also a very complex fibrotic disease with the CRISC score, where actually 3 PRO components, together with lung volume, with vital capacity and skin thickness, make one reliable composite score, which is used to approve drugs. I think this is a direction which also could be used in PSC, and also, of course, the focus on functional liver imaging. I think this is, especially when it comes to treating early disease, which I think we want to go, this is something to be considered. So I've mentioned the CRISC score. And actually, if you think of trial designs, what we do in IBD, and maybe we also can learn a little bit from rheumatology and other neighboring disciplines, where you basically have an induction phase and then re-randomize patients, or have an open label induction phase if it's not randomized, and then look at loss of response. This is, of course, adding to the power. We are currently not doing this due to the highly variable disease course. Maybe when we have imaging readouts or other better parameters than alkaline phosphatase, we can move into that direction. So with this, thank you very much. And, well, I'm not too much over time, am I? Hopefully.
Michael, thank you very much. And due to the bit delay, we have a time for one burning question.
I have a question for you, Michael. You mentioned in the beginning that we should also include or be not too liver-centric on the view of PSC, because we know probably the gut problems will drive cholangitis episodes and disease progression. Yet in the endpoints, this is not really reflected. So what is your proposed solution for the inclusion criteria, as well as for accommodating like this holistic view or gut-centric
to be short, I think it should be part of POs. I think in terms of whether the gut inflammation really drives the disease, that's clear after liver transplantation. But before that, if you look at the dissociation of the activity curves, I think the picture is not that clear. But clearly, malignancy and patient-related outcomes, I think that could be gut-centric or a gut component in that.
But it could very well be that the activity of the IBD is driving some of the other endpoints like alkaline phosphatase, ESR, IL-8. So it should be taken up into the trial design that you can correct for IBD activity. And of course, there are some drugs that also affect or impact on the IBD activity. So these should be as a secondary endpoint.
Couldn't agree more.
So will there be regular colonoscopies in the phase 3 trials?
Yes, but that's easy because each PSC patient with IBD requires an annual colonoscopy anyway.
Okay, thank you very much. And for me as a pediatrician, it's now a pleasure to introduce you Henkjan, who is a chair of the hepatology committee at the SBAN, and he will cover pediatric part of PSC.
Put it on. Thank you very much for inviting me and to comment on the pediatric perspective. I would like to address, after reading the reflection paper, I think I could have been very short because, as the reflection paper states, there's not much place for pediatrics in PSC. I'll try to convince you that needs a rethinking. I would like first to discuss first the age of onset and the phenotype at onset, and then the natural history of disease after pediatric onset. And of course, the important point of potential surrogate markers and the dependency or independency from therapeutic interventions. And to give you a bonus, I'll give you some possibilities to think about to still do trials in pediatrics. So this is the story 10 years ago. 2010, Georgina Mialifigiani from King's wrote that PSC remains underreported in pediatric hepatology. Only small number of papers published in the last 5 years that was, but even before that was even less. And there's persisting little awareness apparently of this condition, although this has improved, I think, the last decade for sure. And studies on large cohorts of children are needed for a better understanding and definition of the pathogenic mechanisms, etc. So what is and I'll allude to a few more recent papers in which they actually now have more data and also natural history data on pediatric onset PSC. So it's good to keep in mind that the majority of pediatric onset occurs in the second decade. However, so as a mean age has been reported, or median age between 11 and 13, indicating that indeed it's the second decade. However, there are still very young cases reported in children at the age 4 to 8, exactly. There's a peculiar thing on pediatric onset PSC. What is not so peculiar is actually that, and here you see a diagram of 4 groups, that IBD, which is the black one together with the gray one, it's here 75% in this overview from Cotter, which is actually very similar to PSC in adult age, anywhere between 50 and 80% as things being reported. But keep in mind at this age, usually it is active and early on IBD disease. There's a more different thing compared to adults, that's the overlap with autoimmune hepatitis, and that's all sometimes called PSC/AIH. However, it's also called autoimmune sclerosing cholangitis in literature, so there's some different names for it. But this is way more than in adult patients. Almost 50% or so have an overlap syndrome in which PSC characteristics coincide with autoimmune characteristics, with or without IBD. And this is so important for the pediatric age that this is a recent position paper from the ESPCAN, as already was referred to, the Hepatology Committee. And this position paper of early this year, which is on pediatric autoimmune liver disease, it was already stated that just autoimmune liver disease warrants very strong emphasis on cholangiography to address whether this is purely autoimmune liver disease as such, or this is actually a feature which is autoimmune sclerosing cholangitis / overlap syndrome. And it was strongly agreed upon by all composers of this position statement, as you can see. And it was also agreed strongly, or just agreed, that you still should treat the autoimmune component in this disease for sure with regular immunosuppressive treatment. It should be kept in mind finally also for the pediatric cases that 33% at diagnosis already has cirrhosis. Whereas we have now discussed on trial designs, we should keep in mind that is 2 different things. If it's either prevention of progress of disease, or is it actually reversal of established disease, which is kind of prevention versus cure. And this is obviously quite important to address. And this may, but does not have to be, a drug does not have to be working on the same routes. So it may be preventive but not curative, it may be curative but not preventive, or both. So this is, I think, to keep in mind that this is based on ISHEC score 5-6, cirrhosis or very severe advanced fibrosis is already 33% a diagnosis at pediatric onset PSC patients. So what happens after pediatric onset? What's the natural history of the disease? I think this is already referred to by Douglas. It's Mark Deneau has published last 2 years data on the natural history based on the largest cohort of pediatric onset PSC disease. And although we have to admit that the natural history database is not perfect, it's the best that we have. They reported on 781 patients with a median age of 12 years and more than 4,000 person years of follow-up. which brings it back to about 6 years follow-up as a median follow-up. And as illustrated here, 33% was combined with autoimmune hepatitis, 76% with IBD, and 13%, which is slightly higher than in adult onset patients, had small duct PSC, which has been related to a benign course of disease, at least in the early years. After 10 years, 38% had portal hypertensive complications and 25% biliary complications. Part of this was in the same patient. So about in total, about 25 to 30% had either of the two complications. And overall event-free survival was 70% at 5 years and only 53% at 10 years. And this, I have to admit that the portal hypertensive complication was defined as hepatic encephalopathy, but also, for example, esophageal varices with or without bleed. So even without bleed was already called a portal hypertensive complication. And of course, ascites, which I think we'll agree on. That's a severe complication. But esophageal varices without bleeding, you may argue to what extent it's very, very important at that stage already. Nevertheless, portal hypertensive complication, as shown here, it progresses in 35% of the patients at 10 years of after diagnosis. And as soon as you have this 35%, this is after diagnosing this complication, it shows that 50%, more than 50%, 60% actually, the next 5 years need a transplant. So you may argue how severe all the different factors are of portal hypertension. As soon as you meet this composite endpoint, your prognosis afterwards is pretty impressive with regard to transplant. Because this is death or transplant, but at this age, this was in the vast majority happily transplant. A similar situation holds for biliary complications, and as said, they may coincide. But this is the biliary complication, 25% in 10 years, but after you have hit the diagnosis, 60% or 50%, no, more than 60% needs a transplant within the next 5 years, indicating the severity of the complication after pediatric onset. So this shows a little bit the comparison of clinical characteristics in children and adults, and I will not go to all the details, but to highlight a few things, slightly more small duct PSC. This is one, and the overlap syndrome, which is way more prominent than in adults. The Mayo Rochester group has recently published the variations in PSC follow-up across the age spectrum of their database. Although they report these as well, I would like to draw your attention to these numbers, which makes them, I think, quietly useless. So I would concentrate on the years up to 10 or 11 years, and it shows that the red line is the pediatric onset, whereas the green line is onset above 60 years of age, and then the probability of the hepatic decompensation. And it shows that the pediatric patients group is maybe a little bit in benefit early on, although overall it's not statistically significant. I'm pretty sure if you do it here, you're pretty okay. However, at 10 years, they seem to add up, and they actually mimic almost the median age, 20 to 60 years group. And there's no leveling off except for the low numbers, only 5 left after this. And mind you, 10 years means at the median age of onset of 11 or 12 years, these patients are 22 years old, still alive to go. The same holds here from the study from Weissmuller, who checked also the disease onset below 20 years of age, which I think we can regard this as pediatric. The cumulative liver transplant-free survival was better up to 20 years of age compared to if you are 60. Mind you, this includes also the discussion on natural causes of death. If you're 60, above 60, your natural cause of death making 80 is different than if between 10 years and 30 years, as you may understand. The cumulative incidence of malignancy is also way lower in pediatric at pediatric onset PSC. So yes, certainly there's a higher liver transplant-free survival, but still it's less than 50% within 20 years. So at age 30 or 33, whatever, more than 50% has needed a transplant, indicating the very seriousness of the disease at pediatric onset. So what are potential surrogate markers and the dependency or independency from therapeutic interventions? And this is the paper that was published by Mark Deneau based on this natural history cohort earlier this month in Hepatology Communications. So it's, I think, very fresh data. And they used a similar composite parameter, event-free survival, and that means no portal hypertensive or biliary complications. Biliary complications, I forgot to tell you, biliary complications is a period of cholangitis together with, which was needed, which forced intervention with regard to a dominant stenosis. So either by ERCP or PTCD. So this is this is rather more clear, I would say, than a portal hypertensive complication. Cholangiocarcinoma, liver transplantation, or liver-related death. So gamma GT below 50 and or a gamma GT reduction of more than 75% by 1 year after PSC diagnosis predicts a favorable 5-year outcomes in children. And this was their conclusion in their this recent paper. Gamma GT has the promise of a potential surrogate endpoint in future clinical trials for pediatric PSC. So it has a promise and potential. That's 2 times, I think, something to discuss. Promise as a surrogate endpoint or promise as a potential, that's even worse, I would say. But that's I'm not English speaking person or not native English speaking person. So this may mean something completely different when you were born here. I'm not sure though. Pediatric onset PSC, 1 year gamma GT below 50 is associated with a better prognosis. And this shows the picture and below the number at risk. So years since diagnosis of PSC, whereas the mean diagnosis was at 11 years of age. This means that this is at the end of their childhood, early adolescence, or early mature age. And it clearly shows the proportion surviving, and surviving should not be read surviving, but surviving is meant no complication as defined before in the composite endpoint. So this has a 5-year, and mind you, this looks impressive, but this looks impressive as well. It starts at 0.6. So this difference between the gamma GT differs between a 5-year event-free survival of 91% compared to 67%. So this is 24%, which indicates actually that there's a major difference, but the difference still is limited and more limited than you would gather from this graph visually at first instance. Now there's something inconvenient because the low gamma GT is associated with better outcome, but UDCA is not associated with better outcome despite lowering gamma GT. So this is UDCA. UDCA in their separate analysis, and I don't show it here, but please be welcome to read it, clearly decreased the gamma GT values, but there's no any benefit in this analysis, in their analysis, of an event-free survival based on UDCA treatment. And this, I think, leads to an inconvenient truth regarding gamma GT as a potential surrogate marker. They do not comment on it really. However, this is just a carbon copy of their text. The relationship between biochemical response to UDCA and long-term liver outcomes seems paradoxical. First, as said, UDCA-treated patients had lower liver biochemistry levels on average compared with patients who were not treated. Second, however, lower liver biochemistry levels generally predicted a more favorable outcome. However, 1 and 2 is not equal to 3 because UDCA treatment by itself did not result in improved outcomes compared with untreated patients. And we know that, and we discussed it before, about ALP in the studies that already was tried. So there's 2 things I addressed here, and I see I have loaded, no, there it is, okay, sorry about that. So this is, I refer to the age of onset and the phenotype at onset. I hope to have convinced you that the natural history of disease is very severe. And actually, because our follow-up is usually ends up by at 20 years, this means at the age of children, it's still, or children at onset, means they are young adults. They are in their 30s, and they have way to go. And as far as we have more data, it does not seem, the complication rate does not seem to level off. No, rather, it just continues. So we can expect at 30, 40 years follow-up, they're all in trouble, as based on the curves that we have at this moment. And we discussed the potential surrogate markers. Just as a bonus, I would like to address 3 points. First, and I cannot agree more within the reflection paper, that the natural history needs to be emphasized. And I think the field needs support and also support for consortia, and maybe certainly not only verbally, but also financially, for delineating natural history. And the natural history, the patient is the patient, remains the patient, but medicine, we do something wrong or we do something difficult, that we have pediatric and adult care medicine. And the patient should not actually suffer from that. They do suffer from that because pediatricians are quite different people in many aspects, and also in their point of care and taking care than adult care medicine, which has good sides and bad sides. However, we should not let the patient suffer from this. Secondly, I miss completely the multiple NS1 trials with patient-reported outcomes on symptom and on quality issues. And I think I would really also underline a point from Martine in the beginning. Doctors usually think of hard endpoints, and EMA thinks of hard endpoints. And I think we all agree that hard endpoints is best. However, the patients, as they live their life, they have, I think they may actually benefit very much in their quality of life of a disease, of a drug, which may not actually change the course of disease magnificently, but change their quality of life. This has I completely missed it in the reflection paper, and I think that's an omission, to my point. And thirdly, after safety and tolerance assessment, because that needs to be done for sure, and I think it also touches the discussion we had on PBC, you may want to allow broad inclusion trials, a kind of pilot trials actually, with post hoc analysis of subgroup efficacy. Because the more we include or exclude specific conditions like IBD, you do not reflect real life. Why wouldn't you go for real life pilot trials and subsequently regular trial designs in these subgroups based on medium or short-term analysis? And I think that's something to consider as well. And with that, I think this was enough bonus. Thank you.
Henkjan, thank you very much. And now is discussion open for the questions, please. Yeah, Deirdre.
Deirdre Kelly, I'm a paediatric hepatologist from Birmingham. I just wanted to support Henkjan's wish that, in fact, we do consider natural history studies starting in childhood for PSC and for many other diseases, and we will get on to talk about NASH in the afternoon. Can I just also ask a question, though, of the learned people opposite me? Do we think any PSC does not start in childhood?
We don't know. There's an elegant retrospective study from the late Ulrike Bromé, who in her 305 numbered cohort looked backwards and looked, but that was with liver test abnormalities, if in these patients liver test abnormalities had occurred already and picked up previously, and the average time that liver test abnormalities were already there was 5 years. And actually, now that we know that you can have PSC, full-blown radiologic PSC without any liver test abnormalities, you might be correct. Also, you could argue that most of the patients with overt pediatric PSC have also active IBD. So it might be that active IBD is promoting PSC, and the more active it is, the the higher the chance that you will get an overt phenotype of PSC. And the reason that because children live much shorter already than adults, is they require much more active IBD in order to develop overt PSC.
So do you suggest to treat more aggressive the PIBD in the case of association IBD and PSC?
Well, in my mind, if I interpret the data that has been generated, also with Mark Deneau's data, that childhood PSC behaves more or less the same as adult PSC.
Well,
I think it depends, really, Cyriel. I think many of my patients have quite mild disease, which then becomes more severe as they get older or move into adult life. And they also present sometimes rather more like an autoimmune hepatitis overlap, and then developing more full-blown PSC as they get older. So I think it can be very variable, and likewise we will see burnt-out PSC in teenagers. So, but the majority, I think, are generally probably subclinical and milder.
But if you look at the clinical event rate in Mark Deneau's series, it's almost the same as in the adult series.
I think there's at pediatric age, it's concurrent with autoimmune hepatitis many times and with active IBD disease. So the phenotype of the patient who has all the three things together may not suffer so much from the PSC component by itself, but may suffer from other, because the patient is one person usually, and they may have three different conditions. And so this is actually, in general, at pediatric age, the PSC component is not the major, drawing the major interest at that time yet. It may be the IBD and it may be the autoimmune component rather than something else. But as soon as they can hit the 3 to 5 years, although they transfer to adult medicine then, adult care medicine, they certainly get already into trouble. And 30% is already in cirrhosis and may end up with transplant in the second half of their childhood.
Maybe we enter the general phase of discussion and still use 40 minutes or so, which we have. I think this is a very important point, and maybe we start addressing the issue whether the study populations which we select are the correct ones for study. In terms of severity, or what I take from the ongoing discussion is whether we consider IBD sufficiently, although we think that IBD is driving the disease. Those are the patients which are mostly excluded, or we only include very mild IBD activity for safety concern. But as Cyriel has pointed out, it may be the opposite, that actually many of the drugs are active enough. So what about the study design in terms of including IBD as an endpoint and also allowing more severe IBD in ongoing studies? Are we ready for that?
Well, I think it all depends on your assumed mode of action. If you want to study a drug that is supposed to regress fibrosis or maybe even regress cirrhosis, probably you don't want to have a patient with a too active IBD that might ruin your trial in terms of competing endpoints. But when you're looking at a drug that is supposed to downregulate inflammation, then for sure you should probably take only patients with who are also diagnosed with IBD, and maybe not too active IBD, because they might need additional biologic treatment, which would also lead to a dropout. So, but in fact, it all depends on what mode of action you're studying.
I mean, that's one of the concerns. I would be interested also in the opinion of EMA. If a patient with active IBD requires intercurrent biologicals, for example, would that blur your signal, or that this also could impact on the course of the disease of PSC as well? So how would you handle that? Do you think we just should take note of that? Should we censor those patients, or what are your concerns?
As you direct the question at me, I can answer this. It has two sides. The one side is, of course, we don't know how IBD therapies do affect PSC activity, and the other problem is that from IBD trials we usually have the exclusion criteria of active PSC. So we're, stuck somewhere where we can't tell what is really happening. We addressed this problem here already when vedolizumab was intended to be studied for a PSC. But at that time point, they could not even tell whether there is any activity from their IBD trials. And this is, of course, the problem that we face. So to make it clear, currently, I think what is stated in the reflection paper that no or at least low activity is the more appropriate thing for inclusion of patients. However, of course, the observation of IBD flares during the trials is a relevant observation to be made. Whether it's an endpoint or not, well, that's another discussion maybe.
Just to finish on that point, but it would help to consider, a bit like Michael said about censoring, or whether you should replace patients. So patients in your study, they enter the study without, they meet the criteria around their IBD, but during the study, which might be 2 to 4 years' time, something happens around their IBD. Should the sponsor be encouraged, is that patient removed from the study, and then they can recruit someone else to maintain their power? But because I do think Michael's right, you need to think about how you handle that as an event and what the confounder might be. Certainly a flare in your IBD could make your liver test very cholestatic. That's well recognized clinically, and it's well recognized that when you treat their IBD, even with very simple drugs, you see improvements in their liver tests. So there can be significant confounders, particularly if an endpoint is defined at 2 years rather than, say, consistent alkaline phosphatase beneath a certain cutoff over a period of time to try and avoid the people who are doing the fluctuations. So it's just another factor to bear in mind.
Well, a mixed measurement design of your endpoint could help in that. If you have a limited flare, let's say 1 or 2 months, you can treat with prednisolone. But it happens unfortunately at the end of your follow-up, where you do your primary endpoint assessment, then you're in trouble. But when you look at a mixed measurement model, for instance, and look at much more and longer periods, longer measurement over time, I don't think it should lead to a dropout. So it all depends on how you design your trial, but at least it needs very, very careful consideration, the IBD in these patients.
But surely, if the two conditions are so closely linked, then during the course of a study, you want to know how many relapses of the IBD had as well. I think that would be a very useful point, at least for us, for pediatricians, where we actually actively go and look for IBD in certain centers. So to me, even if the PSC is well controlled, I still want to know how many relapses they had from the IBD point of view.
Absolutely. I mean, it's also something which matters to quality of life, which we have addressed as well. And I think we are also talking here about the mixed bag. The IBD patient who developed PSC because of active ulcerative colitis. And on the other hand, we have the PSC patients where we have to look for the IBD who undergo the baseline colonoscopy, and we find some inflammatory activity which is not that clinically symptomatic because it's right-sided. So also this is very complex, and I think we are seeing a change that at the early studies basically virtually excluded any level of activity, and I think this has gradually changed, at least allowing some intermediate activity. And as Cyriel pointed out, when you go in with the biological, the whole thing may change because you might hit both the gut and the liver at the same time, and that also may apply to some of the nuclear receptor agonists.
Okay.
Yes, I would like to add to that, also from pediatric case, but also I think from adult case, it really depends on what you want. Because do you want a real life experience, or do you highly select your group to think that your drug may or may not work? And actually, the drug may or may not work in one group and not in the other, and reverse. So I think ultimately, also, let's say that the drug gets there, then you still have to do the experiment. Because real life usually has all the downsides with IBD flares, etc., etc. So isn't there a possibility to start broad and to do an interim analysis and then see by post hoc analysis what your real study has to be done? Because the question makes the design. And now it looks like you want approval for a drug in a very specific small group. That's not real life.
Absolutely. We have a comment.
The solution to this problem is, first of all, look into natural history data again. Look whether data on IBD treatment is available and compare those having flares and being treated with those not having flares. See whether anything comes out of it. And I think the other side of the medal is that IBD developers should be asked somehow to address special patient populations, one of which is the PSC population, of course, and see whether their efficacy they have is similar in PSC patients, and of course whether it influences also PSC activity.
Regardless if the pediatric and adult PSC is the same, so what kind of data we can extrapolate for the adult population as pediatricians? It's a maybe open question to all of you.
Just to comment on the Weissmuller paper, where you looked at the group who were below 20 years of age. That's a very selective group because they got into that group. They were 18, between 16 and 20 when they got diagnosed. So this is a very selective group. So I don't think it's comparable with Mark Deneau's database at all. So I think we need to look at that more carefully because that's the selected group who got that far.
I think I fully agree. I think we only. Both papers do underline that if you have a pediatric onset PSC, you're in trouble for life. And that's, I think, the bottom line. And if you get it at 60 years, you may be 20 years in trouble. But if you get it at 10 years, well, I should say ideally, but that's, of course, not ideally, you're 70 or 80 years in trouble. But that's quite a different, I think that's the notion from both the Nose paper as well as from Weissmuller papers, that early onset PSC is a guarantee that you have a difficulty after 20 years or longer.
I think the discussion, I mean, Henkjan, also what you basically were in favor of opening up, and I think this is happening also in phase 2. If you look at recent designs, also including small duct PSC and overlap syndromes, and being more open there. But then when it comes to phase 3, of course, you have the challenge that you want to prove prognostically meaningful outcomes, and there you have to enrich your study population unless you run an entirely POO oriented trial. And I think you have addressed it at the moment. We try to do both in one study. Maybe this is a wrong approach. Maybe we have to run POO studies,
yes,
and
absolutely.
maybe we have to run endpoint studies.
I really think so. Otherwise, it's not manageable and it does not reflect real life. So why shouldn't you first do this study and then select further on later on?
I tend to disagree. Why can't you also apply PROs in your study, which is supposed to measure halting disease progression? I mean, usually PROs will come out within 6 months, positive or not, and if they are not positive, then it's a lousy drug for symptoms effect on symptoms, and why wouldn't we do that? It's cheap. There's now 3 PRO measurement tools being developed and being validated. The PSC Pro one in the United States, which is a very high C statistic, but is a very complex one. The UK PSC, which I'm not aware of now, and we in the Netherlands have just validated our very simple Amsterdam cholangiographic complaint score, which also performs very well. So I think it's easy to do, and why wouldn't we do that?
I was asking a provocative question. It wasn't necessarily my opinion.
But the problem is that you first need to be defined the outcome, and the outcome can be PRO only. So that's the difference, I think, from your approach. Because sometimes even a drug may be beneficial for patients and may have a clear function if the PRO is clearly working, whereas it may not work on your primary outcome. So that's a completely different point of view, which it certainly is not ideal. It's not the ultimate drug. But if you have, let's put it bluntly, if you would have 20 years from now, but in the 20 years your quality of life is way better, but still remains 20 years, I think I would sign for that.
Oh, sorry. We have a question down there already for a while, and maybe then.
I would like to come back to the choice of outcomes, because we discuss what we can monitor. We can monitor many parameters, but in fact we design a trial only for one primary outcome. So the selection of the primary outcome is very difficult and very important, I think. And I agree also with the others that perhaps quality of life, like pruritus, could be regarded one of the major outcomes. And we should hear the voices of the patients. Perhaps it is not only about the prolongation of life expectancy with the native liver. And coming back also to the effect of treatment, I think that all these biochemical markers really have a little evidence of what's going on in the liver. So still we should discuss other surrogate markers. Perhaps advancing liver fibrosis should be the major markers of the efficacy of the drugs, and we should decide which of those who are now under investigation should be chosen.
Well, there is a strong plea in the guidance paper from FDA to include all kinds of exploratory markers in your trial design, such as transient elastography, such as ELF, such as ProC3. The problem is that these still are not validated. There's a large-scale program called the FICUS study, which is driven by Olivier Chagouillard in Paris, looking at the value of transient elastography in PSC patients. We will have the results in 3 years, but we're dealing with the problem now. So I think we should design our trials, phase 2, phase 3 trials that are, for the moment, acceptable to the regulatory bodies. Which and I think the reflection paper is well balanced to which endpoints you should look, but we should also include ELF and all the other exploratory endpoints, so that in the end we could get rid of the so loaded liver biopsy. But that's the situation, and we should take into account that the regulatory body look differently to what we as academia maybe think is a good thing.
Talking about regulatory bodies.
Yes. No. I want to come back to symptomatic treatments, and of course, just to remind you that the reflection paper does include the possibility of developing compounds only for the symptomatic treatment. It gives two possibilities: to include all the symptoms that are specific or typical for a certain disease, but it also says, well, if you only want to go for one, e.g. pruritus, you can also do this. Now, our question here was, if we do this, if symptoms are addressed and development comes only with a symptomatic treatment indication, then what does this mean to the development of the disease? Theoretically, the improvement of symptoms must not mean that a patient survives better and has no liver transplant or has it later, but it could also mean the opposite. And the question is, do we need to exclude detrimental effects? And if so, to what extent?
I think that question can be applied also to treatments that are going to change the natural history of the disease as well. That we're talking about measuring quality of life to demonstrate a treatment is making things better, and that might be a primary endpoint. But I think also we've got to monitor for symptoms and side effects of treatment. They may make people, it may have a beneficial effect on the on the natural history or some surrogate of that. but also be associated with the worsening of quality of life that is unacceptable to the patients. And I think the reverse is true for, so if you're going to do a study of a quality of life against a quality of life primary endpoint, you obviously, you need to measure surrogates in terms of any detrimental impact it would have on disease. So I think, I personally think both sit hand in hand in any development of new treatments in the disease, PSC.
From the patient side also?
Yeah, from the patients. Speaking as an individual, because of course I cannot check with the others, I have actually two questions or concerns, and it's also related to the remark of Gideon with the, let's say, the confounding factor of URSO. If you have included patients on URSO, how would that affect the outcome of the trial, which can also be the case if you in the end have a trial which is only, or you have a compound that is only targeted for itch or fatigue and will not impact the disease progression. If you then will study disease progression, will that then be affecting those developments? I mean, and actually as a patient, that would concern me, because of course I do like to be able to be treated for fatigue or, well, in my case, not itch, but in the end, I am also very much concerned with all the other factors of the disease which concern in the end liver transplant and all the malignancies. So if I need to choose for that, then I choose personally for the last, and then I go with Cyriel to include the patient-reported outcomes in the pivotal studies of those that will study the other symptoms or actually hard endpoints.
Does that answer your question? Because I think in your reflection paper you were thinking about 6 months short-term trials in terms of improving quality of life, right? And I think the reaction here from this audience was more to include that in long-term studies to answer all those potential concerns. But I think there was a question.
Yeah, but Michael, you must distinguish between pruritus and other symptoms. So,
of
course. So, if you're talking specifically about pruritus and you have a drug that specifically targets bile acids, then you don't. Then the duration of the study. When you're talking about the totality of symptoms, which is a much more complex thing to measure, then it's a different issue. And I agree with Cyriel absolutely. And I think you said it eloquently. PSC is a devastating disease. It is symptomatic, but our patients want to live longer and not have liver transplants, and that's the order of the day, in my opinion.
Thanks for pointing that out.
Yeah.
You had a comment?
No, not specifically, but we ask companies indeed not to exclude IBD, and they agree to include, but then I think also companies need guidance. So there's now some homework for the pediatricians to really come up with a better guidance for the companies and for us as well.
Well,
So
in fact, in the definition process we're endeavoring within the IPC study group, we are trying to define not only what is PSC, what is small x PSC, what is large x PSC, but also how to describe IBD, how to score the IBD, so as to give some help for people who want to design clinical trials.
We have a comment.
A question to the pediatricians. The PDCO, the pediatric committee, is faced with very, very small trials in children, open label trials, and they are faced with the difficulty of how to design a trial that will have some meaningful results. And from what I hear from our experts here, at the moment, none of the biochemical endpoints are reliable, and so would you suggest that histology must be done in all patients at the end of the trial, which is usually about a year, if it's targeting fibrosis?
Yeah, that's one of the questions also here in the list which have to work up about this intermediate endpoint, either combining biochemistry with histology or just histology alone, right? FDA, what I heard from rumors, is basically now relying only on liver histology in PSC and the degree of fibrosis, histological fibrosis. So let's discuss that.
So, well, it depends on the stage of disease you are entering in. If you're already cirrhotic, you may this may not be too helpful. This may be depending on the working mechanism of the proposed drug. But certainly, yes, I think in the histology, as far as we know now, seems to be best predictor. And I know this is at pediatric age. This means usually anesthesia and a major intervention. But yes, ultimately, I think it would certainly give the strongest information. But that's it's certainly true. I don't know if it's at 1 year or 2 years, but yes, I agree.
I've done liver biopsies and histology in a variety of clinical trials before and after treatment. It profoundly affects recruitment. That's the first thing. I think very few parents want their children to have repeat liver biopsies unless they feel it's really there's really going to be some value. I'm not saying you shouldn't do it because I think it does give you good information. But if you're looking for liver stiffness, FibroScan is quite well documented in pediatric patients now. It's a question of whether that would be a suitable surrogate. It's certainly much easier to do and much more acceptable for families and patients.
Well, I think Gideon has nicely pointed out that especially in PSC, you not only have the parenchymal component, but also the obstructive component. So when you have a dominant stricture and you measure in that liver lobe, your stiffness will be very high. So that's one of the confounding variables. And I think that's also one of the reasons about liver histology, but maybe we revisit that after the questions down there. Perhaps, yeah.
Thank you. I just want to say I agree with Professor Kelly fully, but obviously, you know, it's something we use a lot in pediatrics, liver biopsy. But when we talk about PBC as well and PSC, we talked about FibroScan. I'm just fearing that, you know, in the process of discussing these trials, we'll maybe outrun by the developments in the imaging technologies that we have right now, you know, like C-wave elastography, MRE, all these things that will come into and perhaps will thin out a little bit, you know, the patient population. So that's one thing that I want to point out. And the other thing is, are we, in terms of the liver-gut axis, you know, are we ignoring completely the microbiome profiling of these patients? And what do we see, especially from our adult colleagues, the role for this?
Another very important exploratory endpoint you should include in your trial.
Right. So, Cyriel, this combined endpoint of liver histology with alkaline phosphatase, this was basically also the conclusion of the position paper, which you authored and many of us here in the room. And actually, EMA has also taken that up in a way by putting that as a central element. Is that something which you still feel comfortable, or do you think, after having heard there's not only this alkaline phosphatase disconnect, also the gamma GD disconnect, should we just go for liver fibrosis then, histologically, or in the future perhaps by other techniques? Do we still need alkaline phosphatase also as an entry criterion, knowing about the fluctuation and normalization of alkaline phosphatase?
Well, if I try to think of that from the perspective of regulators, I think such a combined endpoint gives the most reassurance at this moment that when you have a drug that is supposed to either regress fibrosis or work on the amount of inflammation, then that gives you the most reassurance for the moment. There's a lot of work going on now, for instance, in imaging. Just a month ago, I asked Christoph Schramm, who is driving the MRI working group within IPC study group, is there already a good measurement for clinical trials in terms of newer MRI techniques? And he said, no, there's not, but we're working on it. So hopefully in a few years' time for larger PSC, this may also be a very good tool. As I said, the FICUS trial is still going on and needs another 2 years of inclusion before we can really say something about transient elastography. So depending on what phase you're in, if you want to go for a phase 3 trial, you want to go to the regulators afterwards with your registration, I think you should rely on these endpoints you just mentioned, some form of biochemical estimate and histology. If you're aiming for a drug that alters disease progression, but if you go for something else, just like symptoms, of course you should go for one of these PROM measures that are now validated. And one other point on biochemistry is that there's also a number of disease models now that have been validated very recently, and there's a new effort going on, driven by Gideon, to try to combine those with readily available data. And disease models usually include much more than only alkaline phosphatase. They have 5 or 6 biochemical measurements, and then some demographic phenotypic elements such as gender or large duct, small duct PSC. And these give you a more may give you a more balanced insight in what's happening in a patient. So disease modeling, like the scores that are now out there, may also be very interesting to look at as a sort of co-primary endpoint in itself.
Marlene, you have a question or comment?
Yes, just a small comment regarding the liver biopsies. So as long as we still need them, and you pointed out, Professor Kelly, exactly, it might be keeping people from joining a clinical trial and other research. The gain might be that to look at techniques, because I have had 5 liver biopsies and 4 were hell, and 1 I walked out of the hospital with a big smile. And it is the difference between what we call the gun and old school, where you just put in the needle. And sometimes it's also in the details, like I got a private room rather than a daunting theater. And those little things, we are here, we patient or advocates, let's work on that. Thank you.
Thank you for that comment. Mitch.
Thank you.
From the patient side.
So I'm wondering, sometimes we're not asking the right question, and sometimes we're not getting the right answer from the question that we've asked. And I'm wondering if we, as a patient community, need a little more boldness, both from the regulators and from the sponsors, to be open to more accidental discoveries by asking much more open questions. When you have a condition that's so heterogeneous, that has so many side effects and so many bits that are just not clear and not known to us, why are we trying to limit the answers we find? Should we not be more open to the answers we can find and then try and extrapolate some more consensus from that open answer?
I think what is going on in current phase 3 trials, that with all the information and all the precious biomaterial which is collected, a lot of scientific questions will be answered in order, to obtain more insights and also in the future hopefully be less invasive. I think that's Gideon, then Douglas, and then we had a question at the end. Piotr was first, I think, and then Gideon, and then Douglas. Yeah.
Okay, I would like to come back to liver biopsy, and I completely agree with Deidre that we should limit liver biopsies in future. At the moment, as the surrogate markers are not well validated, we should encourage investigators to do markers, fibrotic markers, next to liver biopsy, to gain more knowledge, and in future to avoid liver biopsy. So I think that it should be the rule for study planning at the moment.
I hate to say this out loud because Quentin's in the room, but I think we should listen to the comments from Quentin Laurent. We've learnt a lot about histology in NASH trials, and we haven't even talked about the placebo response. And I think, when you sit in a NASH trial presentation, you now look at the placebo first, and you decide what's going on. So one of the things that I have concern about, I think liver histology is a very good endpoint for a phase 3 clinical trial, but I'm wondering whether I will prescribe a drug that doesn't, that the expectation as a clinician is I'd like to see the liver histology getting better. And I think that's a very what we haven't really discussed is exactly how to look at the liver histology. Cyriel's given us a few examples, but we really are, because of the rarity of the disease, we struggle. And, I think in the position paper, you've covered this quite nicely. So I wonder whether I will be able to prescribe a drug if all I can tell the patient is that the liver histology didn't get worse, because then I think it all depends on the placebo group and whether that got worse or whether that stayed the same. Otherwise, I'm worried we won't be further forward. So that's just my thought from learning from the NASH world.
But I think, if I just may add, it's not just the placebo response, it's also the heterogeneity, which is probably higher in PSC than in NASH. But let's see what the reaction is here. Quentin, you are on stage. On the spot.
I was going to tell you the answer to this after lunch, but yeah. But I think you make a number of good points here. First of all, we are dealing across all these diseases with a great deal of heterogeneity. We're looking at issues with sampling. We're looking at issues when we use biopsies about how we actually quantify them, and we have to accept that the semi-quantitative scoring systems we use now are woefully inadequate because they conflate a number of features. I think the direction of travel will be to move away from biopsy. As an interim phase, I think what I like to see with trials is that we're seeing changes in biopsy and changes in biomarker that are running in parallel, and I think that's one of the ways you mitigate against the sorts of sampling error and other issues that Gideon's talking about.
Hopefully all the studies which have used biopsy will produce a lot of biomarkers which we can use in the future. Maybe the last minutes, because you mentioned lunch already, we talk about totality of data, but Douglas, you have something about liver biopsy still?
Liver biopsy. It's just to echo Cyriel's point that I don't think there is a role to have a liver biopsy to justify the entry into a study, which I think is currently written into the paper. But the questions about alkaline phosphatase to Cyriel, just in the high-dose URSO study, the adverse outcomes occurred in patients with mild disease, normal bilirubins, and mild fibrosis on liver biopsy. And in that group of patients, the alkaline phosphatase got better and all the liver function tests got better, but there was a divergence in terms of the clinical events. So written nicely into the document is the requirement for something that shows that kind of sticks with the anticipated long-term outcome for this population. How can we, given that there's only been one study with showing clinical effects from treatment in PSC, how can we then accept a separation of the ALP from the outcomes in that setting?
What do you mean by separation?
Well, the liver function test got better in the high-dose URSO study,
probably
and the ALPs got better. But yes, and that was in patients, and that was not a phenomenon of the patients having advanced disease, because what they went on to show was it was patients with mild disease, with normal bilirubins, with early stage disease on biopsy.
Well, the way the discrepancy was explained was that there is an off-target effect from the very high dose URSO. So it was an off-target effect, and in the majority of patients who URSO or no URSO responded well, was discrepant with the fact that some patients just had an adverse effect of the very high dose URSO, which was an off-target effect, and so that had nothing to do with the response of alkaline phosphatase.
And I think this disconnect was the reason why this co-primary endpoint of liver histology with alkaline phosphatase has been developed. Perhaps we spend the last 5 minutes talking. We've heard it's a very heterogeneous disease with variable outcomes. Why not take all the data which come out of a study? I think this is what you mean by totality of data, if you understood the reflection paper correctly, and analyze that. Because instead of focusing in one direction with such a heterogeneous disease, maybe that's the way to go. What are your thoughts about that?
Well, I think it's a very elegant thought to do so. Also because we still don't know what sample size you should aim for, because we don't know the sensitivity of change of whatever surrogate we're using. We know that alkaline phos has a predictive power. We know that histology has predictive power. We don't know how much the change will be that you need in order to show a difference in the end in clinical effect. So you looking at the totality of data is I think is a very elegant way to overcome this problem if your primary endpoint or your key secondary endpoint will not be positive.
May I answer this or make a contrast to this? I think it is rather a point of not knowing what to do or being in a difficult situation in the end. The reflection paper clearly sets out for an intermediate endpoint where you have to power your study for, but for final outcome studies, history has shown, and it is unclear at this moment whether it is at all possible to power it adequately, and still, if you do so, whether the outcome will be conclusive in the end. And in such a situation where you end up with inconclusive results, which you never intended to have, this is then the potential solution, but it is not, it's far from being clever, of course. It's just looking at the orphan situation that you're in and doing the best out of it. This should be clear. From the regulatory perspective, I think it is, even if it sounds elegant, it is not the best thing to do.
Will it only be applied in exceptional cases? Or can you all say, oh, but my primary endpoint is negative, but please look at the totality of data?
This is the typical situation we are faced when seeing data in orphan disease.
But would PRO be part of this totality of the data? I mean, again, this example of the CRISC score in rheumatology, where 2 PRO or 3 PRO scores at the same level with hard parameters such as vital capacity or whatsoever. What did it take a community to convince you, and I think also FDA, to accept such a composite endpoint?
Well, it is difficult to predict. I'm not the CHMP who usually decides about this. When deciding about totality of data and what can be made out of it, it is usually not picking something that has performed best, because cherry picking is usually inflating the type 1 error to an extent that is not acceptable. And therefore, I would think if for instance, looking at symptoms, the symptomatic outcome is in accordance with all the other ones that may have not achieved statistical significance, then this could be something acceptable. But if the symptomatic outcomes are the only ones, and others do not show anything, or even have detrimental effects, I think this would be very difficult.
But at least you would suggest that the totality of data is pre-specified as an endpoint in any trial design. Okay, thank you.
2 more comments, Bettina, and then...
I got 2 points. I think Cyriel pointed out a very important thing, especially it counts for PBC as well, but PSC especially because this is such a difficult disease and with multiple things going on, that those new risk scores that are out there should be explored more, because those might capture more what you would like to see a benefit, and not only on ALP, but a total risk score. I mean, they're not developed for nothing. Right. I think we really should explore that much more. That could be even a better surrogate than anything else. And with respect to quality of life, I truly understand that you want to improve the quality of life, I do, but I also know that in trial designs that is very difficult, because you have, it's much more bigger variations than the harder endpoints, and that makes it sometimes in the trial designs is so difficult to take that into account because it's much more fluffy, and to really state hard things on quality of life is difficult, and I think that's something that EMA or FDA are really struggling with. I think you would like to have it in there, but it's just and pharmaceutical industry as well. But it costs you just a double amount of sample sizing.
That was a perfect concluding statement, but if there is one very urgent question, now the bar is very high. I will allow one more question.
It was not really a question, but it's in our regulatory house, obviously, if you talk about totality of data, that is really something that is really, really last resort. You need to have your drug and you have to understand it. So you have an endpoint, a primary endpoint. That one should really be driving the discussion. And if you then, what you described, Dr. Ponsioen, was really something that, okay, well, we saw an off-target effect, which explained why the primary endpoint didn't work, but the totality of the evidence in that subgroup, that is not a very strong argumentation, I would say. It's an hypothesis, and we approve drugs really on a positive benefit risk. So I wanted to push back a little bit on that. Sorry.
We as scientists are taking away. We thought we were talking about big data and artificial intelligence already. Okay, thank you very much. I think this was a very stimulating discussion, and we've deserved lunch.